So I think John has done a lovely job of showing us how we identify melanomas. And then as dermatologists, we're often the first port of call in managing these melanomas. And John's already gone through this, but just to recap, the incidence of melanomas is increasing worldwide. At this stage, if someone is born in 2015, their projected risk of getting an invasive melanoma throughout their lifetime is 2%, or 1 in 50, which is a very high number. It's the most common cancer in Caucasian women aged 25 to 29, so it's a young person's disease. But the great news is that early detection and appropriate excision can lead to a cure in 90% of early melanomas. And that's where we as dermatologists come in. We want to increase that proportion of people that have been found early and treating them appropriately. The mortality rate is actually highest in white men, and I think that may be because men aren't as attentive to their skin as we women are. So we notice the smallest of changes. Men aren't quite the same. It's often their wives that send them to me anyway. So managing a melanoma. So when we've identified a melanoma with all of the tools that John has just talked about, the next thing we need to do is get a biopsy. So a full depth biopsy that can adequately measure the thickness of the melanoma, but with narrow margins. And that's to make sure that if the tumor is thick enough, that we can then send the patient on for a sentinel node biopsy, something that Dr. Prescott is going to talk to us a little bit more later on. And it's so important that we get an adequate specimen because tumor thickness is the best predictor of prognosis. So knowing how thick that tumor is guides not just our management, but also can tell us the prognosis or estimate the prognosis that that patient has. The next important factor when we look at a pathology report or even clinically a melanoma lesion is ulceration. So that's the second most powerful factor. Having an ulcerated lesion actually brings patients from stage 1 to stage 3 disease up a level in staging. Then for the very early melanomas, the other factor that can be important is the rate of how it is dividing. So in stage 1 melanomas, if it's rapidly dividing, again, it brings the patient up another level. So some of you may be familiar with this staging system, especially if you have more advanced melanomas. But when we look at thickness, we rank patients into 4 different levels of tumor thickness. So less than 1 millimeters, which is considered an early melanoma, between 1 and 2, which is T2 stage, then between 2 and 4, and then patients with the thickest melanoma, so greater than 4 millimeters. And for each of those T levels, if somebody has ulceration, it brings them up a level. So it makes their melanoma a little bit more aggressive or serious. So when it comes to our excisions, especially when we are removing the lesion to fully remove it before we send the patient on to Dr. Prescott or Dr. Cowie, the amount of healthy tissue we take around the actual melanoma varies on the thickness of the initial one that we saw on pathology. This has been looked at in several big cohorts, looking at the advantage of taking more healthy skin. And the principle behind that is that you're not just taking the melanoma, you're trying to prevent any tiny microscopic disease from allowing some of the melanoma persist. So for in situ melanomas, there are melanomas that actually haven't become invasive yet. We take between 0.5 centimeters and 1 centimeter. That can be a little bit higher when it comes to lentigo malignans. They're the type that John showed on the face, often on the face, the large lesions which aren't very aggressive, but the microscopic spread can be more. Then for the T1 type lesions, so that's less than 1 millimeter, we take 1 centimeter of healthy skin around the lesion. Once we get deeper than that, between 1 and 2 millimeters, we take between 1 and 2 centimeters, depending on the size and the aggressiveness of the tumor and pathology. And then for melanomas that are greater than 2 millimeters in depth, we take 2 centimeters of healthy skin all the way around the lesion. Now, there was debate in previous years as to taking up to 4 centimeters of healthy skin around the lesion, but that hasn't been shown to help in any way. So it's more conservative now without decreasing the patient's prognosis. So Dr. Prescott is going to talk much more on the topic of sentinel lymph node biopsy. So I won't go into the actual process, but what's important for us as dermatologists is to know when to send our patients to Dr. Prescott. So we've over the last 10 to 15 years, we've learned a lot more about staging patients, and it's been shown that knowing the status of a patient's nodes, whether we can feel lymph nodes involved or not, is one of the most important prognostic factors for them. So patients with a T1A melanoma, so that's a patient with melanomas that are early, so they're between 0 and 1 millimeter, don't need a sentinel lymph node biopsy, apart from in exceptional cases. Patients who have a melanoma more than 1 millimeter deep, they're referred for a sentinel lymph node biopsy. And then a small proportion of patients who have between 0.75 and 1 millimeters, if they have ulceration or a more rapidly dividing melanoma, we'll send them on for sentinel lymph node biopsy. And in exceptional cases, when the pathology of the tumor seems very aggressive or the patient's very young, we will consider a sentinel lymph node biopsy when it's smaller than 0.75 millimeters. When we grade nodal disease, and this is more relevant to our surgical oncologists and our medical oncologists, we look at the nodal disease as the presence of one node, which is considered a low burden of nodal disease, between 2 and 3 lymph nodes involved, or 4 or more lymph nodes involved. And then each of these levels, we can look at whether it's just small microscopic disease or if there's palpable, or what we call macroscopic disease present. And that can also affect prognosis for a patient. And then moving on to metastasis. We group metastasis in 3 different levels again. Most commonly we see metastasis going to non-visceral sites, and your viscera are the organs of your body. So that's distant skin sites, the subcutaneous levels, or below the skin, or to the lymph nodes. And that is the type of metastases that have the best prognosis. The next most common are lung metastases, and they're considered less serious than the other type of organ metastases. And after that, we have all other organ type metastases. So after lungs, the most common are liver, then brain, then bone, and even to the gastrointestinal tract. So we have a very complicated staging system, and I think even some dermatologists have problems understanding exactly where patients fit in. But to summarize this in layman's terms, or more understandable terms, stage 1 and 2 mean that it's confined to the skin, and there is no lymph node involvement. The prognosis for these patients are very much related to their tumor depth and whether there's ulceration present or not. Stage 3 refers to patients who have lymph node disease, and their prognosis is related to the burden of lymph node disease that they have. And then stage 4 is the presence of any metastatic disease. So looking at the types of melanomas that we primarily look after in the dermatology setting, that will be stage 0 to stage 2. And we have recommendations from the American Academy of Dermatology on how to manage these patients. When patients are in stage 3 or 4, which is lymph node disease or organ disease, they're under the care of surgical oncologists and medical oncologists. So looking at stage 0, that's melanoma in situ, or melanoma that hasn't invaded further than the epidermis. And we can see that in this little diagram, if I have my pointer, the tumor hasn't invaded any further than the epidermis. And these melanomas in situ are not yet invasive, so they won't spread to other parts of the body. These patients have an excellent prognosis, and the treatment is typically with just the wide local excision that we showed before and 0.5 centimeter or 5 millimeter excision of healthy skin around that. Now, in some cases, we'll go as far as 1 centimeter diameter around, typically in the case of the lentigo maligna on the head or neck. There is no imaging indicated in these patients because these patients should not have any other burden of disease elsewhere. The next is stage 1 melanoma, and this is defined as melanomas that are less than 2 millimeters with no lymph node involvement. But these patients, we can see here, if I can find my pointer again. Okay, I can't find my little arrow, but if you can see in the diagram, this tumor has now invaded a little bit further into the dermis, or what's below the very top layer of the skin. Oh, here. Perfect, thank you. Excellent, okay. So, with this tumor, it's invaded a little bit further through the top layer of the skin, but less than 2 millimeters into the actual skin depth. With these patients, we do a wide local excision with 1 centimeter of healthy skin taken from around where the melanoma was. And a sentinel node biopsy is indicated in some of these patients. So all patients with tumors greater than 1 millimeter in depth, ulcerated tumors, those that have positive biopsy margins. So when we took the initial biopsy, there was still tumor left at the deep margin, so we can't accurately assess how deep that actual melanoma was. And then in patients who have more aggressive melanomas on pathology. Stage 2, we see that the melanoma is invading further still into the skin. These melanomas are defined by their thickness, their ulceration, but again, they have no lymph node involvement. Depending on the aggressiveness of the melanoma and the size of the melanoma, we take a wide local excision of healthy skin between 1 and 2 centimeters. All of these patients are referred for sentinel lymph node biopsy, and in a certain proportion of patients, we may consider imaging to assess them in the beginning or to follow to continue surveillance in the future. These are the only patients between stage 0 and stage 2 who should have imaging. There has been no improved diagnostic ability with blood tests, chest x-rays, although they're still done routinely in some places. So they're not indicated and they don't help us pick up disease. A small proportion of these patients may also be considered for adjuvant therapy, which would be chemotherapy, and typically in a trial setting. So looking at thickness again. Thickness is very important when it comes to prognosis for patients. So here we see the 5-year survival rate for patients with different stages of tumor thickness. So for up to 1 millimeter in depth, the 5-year survival rate is excellent. So in patients who don't have any ulceration, it's 95% at 5 years. Ulceration lowers that slightly to 91%. Between 1 and 2 millimeters, there's an 89% survival rate in patients who have no ulceration. And then that goes to 77% in patients that do have ulceration. So you can see once ulceration is present at every level, it just makes the prognosis that little bit worse. Between 2 and 4 millimeters, the 5-year survival rate is 79%, or 63% with ulceration. And when it's greater than 4 millimeters in depth, the 5-year survival rate does fall to 67%, or 45% with ulceration. So with each level of depth, having the ulceration makes things increasingly worse. And this will be gone through again, but looking at prognosis and stage, we can see for stage 1 and 2 disease, which is the majority of the patients that we see, that the survival is excellent for stage 1A, stage 1A and B, and stage 2A disease of 5 years and 10 years. The survival rates then start to drop off slightly within the later stages of stage 2 and stage 3. And then stage 4, the 5-year survival rate is 15 to 20%, or the 10-year survival rate 10 to 15%. Now these are based on figures that were collected by the AJCC and published in 2009, based on all the years, the 10 years preceding that. I think Dr. Cowley's talk is going to explain how things have changed significantly. So I hope when the next ACG guidelines come out, we'll see a big difference in these stage 3 and stage 4 survival rates with all of the new targeted therapies that we're seeing. So I think what we're seeing here is a lower than what we're expecting to see in the coming years with all of our new treatments available. Looking at the major prognostic factors of survival, the major ones that were shown when they did the big analysis on those 13,000 patients were thickness. Again, that's very, very important. Ulceration, mitotic rate, which means the rate of division of the cancer cells. Age, so people with older age have a worse prognosis. Sex, so males have a poorer outcome for localized disease, and that might be because of their delay in presentation. Anatomic site, so melanomas of the trunk, head and neck have a poorer prognosis than those of the arms or the legs. The number of lymph nodes, so the lymph node burden, and also whether those lymph nodes that are involved can be felt on clinical exam or not felt. So whether they're just, whether we can see them or if they're just microscopic lymph node involvement that we pick up with pathology. And then the site of distant metastases. So visceral or organ site metastases do have a worse prognosis than those that occur in the skin, the subcutaneous tissues, or the lymph nodes. So on to a different category of melanomas. And this is something I think we encounter a lot in dermatology clinics. This melanoma is a disease of young people, especially the earlier stages of melanoma. So we do have pregnant women who come in with suspicious moles, and it's always an area of difficulty for us. Somebody has a suspicious mole, and do we wait till the end of the pregnancy to biopsy it, or go ahead and biopsy it then? In clinical practice, if there's any real suspicion that it's melanoma, we do the biopsy then. The benefit of taking a biopsy and hopefully improving survival far outweighs the risk of an injection of local anesthetic. One of the things to know is that 10% of women have darkening of their normal moles during pregnancy. During pregnancy, the way we pigment changes. Any of the women here will know that often they develop a black line down the center of their abdomen, or a linea nigra, as we call it. And because of the estrogen receptors on our moles, often moles will darken or even change in color or shape. So we have many frightened women who will run in and tell us that their moles have changed. So often we can reassure them. It's part of pregnancy, moles will change. And it's been shown that pregnancy doesn't adversely affect melanoma risk. So if we do detect a melanoma that we take off, the fact that a patient is pregnant doesn't mean that their risk was higher or that their outcome is worse. Similarly, there was concerns about the oral contraceptive pill. So the estrogen receptors on nevi, would oral contraceptive pills accelerate melanoma development? And I think we've shown quite well now that it doesn't have an adverse effect on melanoma risk or progression. So when it comes to melanoma in pregnancy, if we detect a stage 1 or stage 2 melanoma, which means it's confined to the skin, there's no lymph node or organ involvement, we excise it using all the parameters we talked about before with the a margin of healthy skin around it. When it comes to stage 3 or stage 4 disease, so lymph node involvement or metastasis, there has to be discussion, typically with Dr. Cowie here, about the risks versus benefits of having immunotherapy versus chemotherapy during a pregnancy. And one of the important things that we need to counsel women on, so when I have a woman come back to me who's had a melanoma, is can she get pregnant again? Or will getting pregnant again increase her risk of her melanoma recurring or her getting new melanomas? The answer is no. Becoming pregnant again doesn't increase recurrence risk, but because we know that the vast majorities of melanomas recur within the first 2 to 5 years, we advise women to avoid pregnancy until that 5 years has passed, unless it's a very early melanoma. John has already touched on familial melanoma, or when melanoma runs in families. This is a very small proportion of melanomas. And a lot of patients will ask us if they need to have genetic testing done, in the way people often will have it for breast cancer. The answer is no, unless they have a very strong family history of melanoma. So more than 3 of their first degree relatives having melanoma. The most common mutation we see for hereditary melanoma in the US is the CDKN2A mutation that John talked of. And a patient with that mutation has a 76% risk of developing a melanoma. So they are in the high risk category. And 15% of those patients will also go on to develop a pancreatic cancer. So if we've identified a patient who has that mutation, they also need to be screened for the development of pancreatic cancer, which can be one that's asymptomatic for a long time, so they will need screening. We only test for these gene mutations if there's a strong suspicion. There is no advantage if it hasn't been a very strong family history in the patient. So recurrence. One of our biggest jobs, once a patient has had a melanoma of any stage as dermatologists, is to detect recurrence of the melanoma. For stage 1 and 2, it's typically local or regional disease, whether it be in the skin or the lymph nodes. And in the further on stages, it's typically distant metastasis. So a local recurrence, which occurs in 4% of patients with stage 1 or 2 disease, is defined as a recurrence within 2 centimeters of the primary melanoma, so within 2 centimeters of that scar. If it's further than this, but it hasn't quite reached the lymph nodes, we call it an in-transit recurrence. Then we can have lymph node recurrence, which we look at using lymph node biopsy or an aspirate of the node, and we go on to do imaging afterwards. And for distant recurrences, we treat them as metastatic melanomas. And this is an interesting study. It's an old study, but it very much guides the way we follow patients with melanoma today. So these are for patients who have, this is a recurrence curve for patients who have melanoma confined to the skin. So you can see that regardless of how deep the melanoma was, the vast majority of recurrence happens in the first 2 years, and nearly all of them occur within the first 5 years. Now, there are some melanomas that will occur later down the track, but once we get to that 5-year point, we don't have to as stringently monitor our patients, and that's a very important number, and that's what guides the guidelines we have for following patients today. Lifetime surveillance is warranted in all patients with melanomas because we do know that there are people who do recur much later on in their disease. And the objective when we're screening these patients back in our dermatology clinics is, first of all, to detect potentially curable regional recurrences, so the recurrences that happen near the scar of the melanoma, and then to detect new primary melanomas. So we know that patients who've had a melanoma previously are at higher risk than other patients of getting a second melanoma, 3.5 to 4.5%. So double or almost triple the risk of other patients. So we're not looking just for the recurrence, we're looking for new early melanomas elsewhere. As I said, the risk of local recurrence in these early stage patients is greatest in the first 2 to 5 years. So 90% of patients will recur in that first 2 to 5 years. So that's the crucial time to be extra vigilant and have the patients come back more often. But there is ultra-late recurrence. So even after 15 years, patients can have a recurrence locally of their melanoma. And then, of course, we have to keep in mind that if a patient has had all the risk factors to develop a melanoma in the first place, well, of course, they're also at increased risk of developing other skin cancers, such as basal cells and squamous cells. And we all of us have patients who have multiple variants of each, so multiple basals, squamous cell carcinomas, and melanomas. So our current guidelines for patients who have had melanoma in situ, which is stage 0, at least an annual exam with a dermatologist. Stage 1A, we want them to have a full body exam and a lymph node exam every 3 to 12 months for the first 5 years. So depending on the patient's level of comfort and how aggressive that melanoma was, we see them every 3 months. Some we'll see less frequently for the first 5 years, and then those patients will all be seen annually. For greater stages, stage 1B to stage 3, full body exam and a lymph node exam every 3 to 6 months for the first 2 years. And as we know, that's where the biggest peak is. And then we start seeing patients every 3 to 12 months for the next 3 years, and again, annually afterwards. As I said before, scanning is not indicated in patients from stage 1 to 2A. It doesn't help us detect earlier recurrence, and it does put patients through unnecessary anxiety and also expense. We do use imaging to guide our surveillance in stage 2B and higher. So other recommendations. We advise all of our patients to examine their skin every month and examine their own lymph nodes. And the way I tell my patients to look at their skin is to look at each limb, so each of their arms, each of their legs, and then to divide their body in 4. So look at each of the quadrants of their front and their back. And if they need somebody to look at their back, they can have a partner that will do it. Having your own photos, so own clinical photos, knowing what's on your own skin can help greatly with that as well. Sun protection is obviously key, so using a broad spectrum sun protection factor that blocks out both UVA and UVB. A lot of our sunscreens block out UVB very well, but not so much UVA. And in Texas, UVA is very important because UVA can go through windows. So we drive much more in Texas than we drive elsewhere. So a lot of my patients come in and the left-hand side of their face is older, wrinklier, and they're starting to get their pre-cancers and their cancers on that side first. Avoidance of tanning beds. I think John has illustrated how important it is to avoid tanning beds. A 20% increase in risk after one tanning bed alone. Screening family members. So if other family members have multiple nevi, they should be screened and checked at least on an annual to biannual basis. For those difficult patients who have more than 100 moles, taking total body photography or sequential dermoscopy is very important to detect change. Change is probably the most important thing in patients with 100 nevi or more. So either new moles or moles that are changing. One of the things I see a lot in patients who've had melanomas and who've been very frightened by their melanoma is they come in and they ask me to take off all of their moles. They don't want any mole left on their body that could turn into a melanoma. The issue is that only 30% of melanomas occur in previous moles. 70% are new moles. So taking off all of somebody's moles and leaving them with scars all over their body doesn't improve their survival significantly at all. It isn't akin to getting a prophylactic bilateral mastectomy in breast cancer. Taking off pre-existing moles, unless they're clinically suspicious, does not help. Now, we do remove any suspicious nevi that develop after that, and again, with narrow margins, so we can still be open to sentinel lymph node biopsy. Another thing I've been asked frequently by my patients who come back after they've had melanoma is about their diet. Has anything that they've been doing in their diet adversely affected their prognosis, and if there's anything they can do? And this has been looked into in great detail. Very few things have been shown to improve melanoma prognosis when it comes to diet. There has been a potential benefit suggested by decreased alcohol intake and also vitamin D supplementation in patients with high-risk melanomas. Now, it's important that when our melanoma patients are following our guidelines and wearing their sunblock adequately, that they may become vitamin D deficient. So supplemental dietary vitamin D and checking your vitamin D annually is also important. So I think the basis of my lecture is really that early recognition of primary melanoma, whether it's your first or your second, and early recognition of regional recurrence is crucial. Thank you.